Hello, good evening, Dr. Garima here, and today we'll be solving another scenario from the Australian Dental Council practice paper, which they have just released, and this is clinical scenario number 5. A very important question again. Caries management is one of the favorite topics of Australian Dental Council written exam, and they will definitely ask 5 to 6 questions upon this. Now, caries management particularly is not given in any textbook as such, as in like how to manage caries. There are basic concepts given in your student, how to prepare a cavity. Grossman says what happens when the caries is reaching pulp. That's the endo stuff. But caries management particularly is more of a pedo topic because it says how to remineralize caries. It's a part of conservative dentistry also. Like student will also give you how to manage caries and how to prepare the cavity. But it's pedo conservative topic both, because prevention also comes into it. Community dentistry also, or public health dentistry also becomes a part of it. But there won't be a particular book which is just giving you the precise details. So from articles you get this information. So I would just like to show you from where the ADC is asking these questions. They have given out their question bank with the name of the place where they are getting such questions from is the European Society of Endodontology position statement, management of deep caries and the exposed pulp. So mostly they are minimally invasive dentistry and the deep caries management of the exposed pulp. These are the areas where you would know where the caries management is coming from. Now, of course, they have just given the name of this. I've gone and opened that resource, read it and formed questions exactly like the ADC kind of a question bank, and I have included that in my book called as Ultimate ADC Written Companion, which has 1400 SBQs from all the ADC resources that they have mentioned on their website. Alright, so I'll directly jump on. So because we are solving that question, I've just mentioned here caries management, and we have so many pages for caries management. You can just pause this video, have a look at the screen and see how the question is made, what is the answer, what is the explanation, and from where the resource had come from, correct? So I'll resume this video, but you can choose to pause it and just go ahead and have a look at it. If you really wish to have this book, you can just email me on adcwrittenmocktest@gmail.com and I will send you a sample copy. If you like it, you can just send me a request to purchase it, and I'll forward you the entire book on your email. But anyways, let's go back to the question. I just wanted to give you in detail where the ADC is getting these questions from, because if you study from the right resource, more chances of passing the exam, right? So let's go back to the practice paper. This is released by ADC itself. The answer key is given at the end of all the practice sessions. But we'll see how to solve this question. Caries management is a bit of a tricky question because different countries, different ways they teach the students, but you have to follow the guidelines what is given by the ADC resource and the Australian guidelines, because you're giving that exam. Now let's go back to the question. What they have said is Ms. Khatri presents for a checkup with no particular complaints. No complaints. This is very important because it means that there are no symptoms, and that's why she's just come for a general checkup. She has a large number of resin composite restorations. Okay, that means she previously had a lot of caries and right now no complaints, but she does have a lot of composite restorations. You decide to obtain bite wing radiographs. The right side is shown. Okay. Now this is the first image of the radiograph. What should you do when you see a radiograph? And this will help you clinically also. The first thing you do is always observe the corners, is there is a cone cut or not, because that's a technical error. The second thing, you see the radiograph itself. Don't see the tooth, just see the radiograph. You will see that, so to explain this, let me explain you this. This is a normal bite wing radiograph. You see there here on the screen. There is very minimum gap between the upper and the lower teeth because the patient is properly biting on that occlusal holder phlegm. If you have ever taken a bite wing radiograph, you ask the patient to bite on and then you position the cone and then you shoot an x-ray. By the way, how to obtain a bite wing radiograph will be one of your skilled OSCE tasks, so make sure you know how to do it. If you have never done bite wing radiographs, please YouTube how to do it. So then you will know how these radiographs are obtained. Now, an ideal bite wing radiograph should have minimum gap between the upper and the lower teeth, and all the teeth should be kind of straight, like the angulation has to be very parallel, and there should be no overlap of the teeth. If there is overlap, that means the angulation was faulted, and the entire phlegm should be exposed properly. There should not be any cone cuts or something. If you achieve that, then that is your ideal bite wing radiograph. Now I'll go back to the question. Now if you compare this x-ray to that, you will see there is a big gap between the upper and the lower teeth. Not even the full crown structure of the upper teeth is exposed. If we go back to the previous bite wings, almost 3/4 of the tooth is visible except the apices of the teeth. But the entire crown is visible, half of the root is visible. But in our given question radiograph, that is not there. So that is one error. Having a cone cut is the second error. Okay. So you should remember these things, because your sub questions may have a question about this. Radiographic questions will be asked. Okay. Now you have seen the x-ray, and the first immediate thing your eye will catch is a nice radiolucency out here. Understood? So anyways, you just keep that in the mind and you follow the sub question which is asked, because now you start answering the questions. On examining the right bite wing radiograph, you note a radiolucency affecting the distal surface of tooth 4-6, which is this one. What symptoms would Miss Khatri be most likely to indicate she's experiencing in relation to this tooth? Okay. Now let's just see this tooth. First of all, what did the patient say? No particular complaint. So she's not given any symptoms. Secondly, when you see this radiolucency, you see there is a composite filling done, and this radiolucency is still within the composite restoration. It's not going in the dentine, because there is no communication between the exposed tooth structure and the dentine. The patient likely is not going to have any symptoms at all. If this radiolucency would have grown further and touched the dentine or got in communication with it, probably the patient would start having sensitivity or some symptom. But right now, because it's still within the composite, it's like an air bubble in the composite, the patient is not feeling anything. So what symptoms would Ms. Khatri be indicating? Options: sensitivity to biting pressure, cold stimulus, eating, hot stimulus, no sensitivity. So like I mentioned, it is no sensitivity. I think my video paused. Let me just check. Yep, I'm back. But I hope you could just hear my voice. But anyways, yeah, so the answer here is no sensitivity. Why? Because this radiolucency is not communicating with the dentine. So you see, we have 5 options here. Sometimes there can be 4 options, sometimes there can be 5 options. So the answer is E here, and now you know why. You also observe a radiolucency on the mesial surface of tooth 4-7, and during the distal cavity preparation of tooth 4-6, you are able to directly assess, like you can visualize the mesial surface of tooth 4-7. What is the primary factor that should be considered when deciding whether to surgically manage mesial surface of tooth 4-7 and place a restoration? What is this question trying to say? The question is saying you decided to fix this, okay? Now you are drilling this. When you drill this area, there is a gap between these 2 teeth, correct? Before you're doing the filling. Right now you have just drilled. Now because of the gap, you can directly see the mesial surface of this tooth, which otherwise you won't be able to see because of the contact. Now when you see the surface, and on the radiograph you did see a slight radiolucency out here on the radiograph. But when you're actually seeing it directly, when would you decide to go ahead and fix that or just leave it as it is? What factor is going to influence your decision? And I'll tell you, the factor is cavitation. You may see a white spot there, you may see an arrested lesion there, but if it's not cavitation, like if there is not a proper hole, then you are not going to fix it. Arrested caries, you're going to leave it as it is. Demineralization, you will put fluoride or something, but you're not going to poke it with anything, because a demineralized lesion can remineralize, you understand, and your aim is to do the most conservative and minimally dentistry procedures. So only if there is a hole that you're going to go and fix that issue. Understood? Like in any carious lesion. So now when you have understood this question, let's see the options. So what factor would I be considering to decide whether to manage this site Okay, like to leave it or to fix it. The radiographic appearance of the enamel. No, I'm not just going to rely on radiograph because it's still on the enamel. The progress of caries into dentine. Well, if the caries has progressed into dentine, then I would definitely see the radiographic feature of the caries in dentine, which is not there. The degree of demineralization. The degree of demineralization. It's still demineralized. It's not cavitated. The presence of cavitation. Yes, that is the answer. Ms. Khatri's oral hygiene. That is relevant, but not so much for me to decide whether I should fix that issue or not. Only if there is cavitation will I touch that tooth and restore it. If there is no cavitation, I will wait and watch. I will put fluoride. I will ask her to floss, etc., etc., etc. Understood? So the presence of cavitation is the correct answer here. On further examination of the radiograph, where else can radiolucency be detected affecting enamel and dentine in an unrestored tooth that will need to be managed? So the question has said, where else can you see cavity in an unrestored tooth? That means the tooth doesn't have a restoration. So 4-7 you can see this. Okay, am I going to fix that? It's still in the enamel. I would assess clinically. Now there is a nice radiolucency which is out here, which is just about to penetrate the dentine, and it's interproximal out here, which you cannot see clinically. So these two places is where I would be focused on seeing my radiolucency. Let's see what the options say. Distal surface of tooth 1-4. 1-4 is this? No. Distal surface of tooth 1-5. This. Still the enamel is pretty much intact, it's not broken, so no. Then we have mesial surface of tooth 1-7, distal surface of tooth 4-5. Mesial surface of tooth 1-7, no, this is okay. Distal surface of tooth 4-5, yes, this, like I mentioned, it's a nice hole happening out here. And occlusal surface of tooth 4-7, this is what I said, right? This. So again, what is the question saying? Where would you need to manage the issue? Now I would say I have to manage this issue and this issue, but if I have to choose between these two, then I would choose tooth number 4-5 because it's interproximal. Occlusally, you can even create a small smoothing, like a crater, like a thing which can be self-cleansed, okay, or you can practically see occlusally if that area needs to be fixed. But it's not crossing the enamel border and going into dentine. Neither it does it seem that it's going to breach it so frequently, I mean so fastly, the dentinal DJ junction, basically dentino enamel junction. Plus this is more of a cleansable area. But this, it's a deep cavity, and though it's still in the enamel, it seems as if it's going to breach the dentino enamel junction very fast. And interproximally, it's difficult to clean as well. So if I have to manage between these two cavities, though I would say both of them need to be managed, I will go with distal surface of 4-5. That would be my answer. Though choosing occlusal surface of 4-7 is not wrong, but if I have to choose one tooth, then I'll choose the one which is having interproximal, because that area cannot be cleaned otherwise. Understood? Now, if your overall management of Ms. Khatri's early carious lesions involve treatment to encourage remineralization, what approach would be the most effective? Most effective. That means all the approaches are right and the options most effective I have to choose in making Ms. Khatri's enamel less acid soluble. Okay. Application of topical fluoride gel yearly. Increased consumption of cheese and milk in her diet. Increased daily water intake. Use of fluoride tablets. Brushing twice a day with 1200 ppm of fluoride toothpaste. Something which is done yearly is not going to be that effective compared to something which can be done daily, correct? Use of fluoride tablets. Fluoride tablets are banned. They are not used anymore. So I cannot choose that, though it won't be a wrong answer. So if I'm stuck, I would be stuck with option E, which is the direct answer. Like I would want her to use something which helps her in a daily remineralization, and that is using a fluoride toothpaste. If there was an option of applying varnish like every 3 months, even that would have been a good answer, because that's a high concentration of fluoride varnish, but they have not mentioned that. If they would have said use a fluoride mouthwash like weekly or something, even that would have been a great answer. But still, compared to anything which is weekly, yearly, bi-yearly, something like that, you still should choose something which is done on a daily basis, and 1200 ppm if a good fluoride concentration is great. So brushing twice with it will not only ensure that oral hygiene is maintained, but also will make sure that fluoride is being supplemented to the teeth, which will help in remineralization, which is what your question is asking. You know, these questions look simple, but now when I'm solving it, you will know that, you know, it's a little traps, and maybe unless I would have answered this question the way I have, probably you would have made a mistake, you know. Let me know in the comments if you actually did make a mistake and then after listening to my explanation you thought, okay, I should have thought that way instead. Well, and the last question of today, what is the main technical problem with using this bite-wing radiograph for assessment of Ms. Khatri's teeth and periodontal support? And periodontal support. To see periodontal support, you need to see some of the periodontium. And what is periodontium? It's your cementum, it's your lamina dura, it's a little interradicular bone, you know, that is your periodontium. So, technical problem. You remember in the starting of this question, I showed you an ideal white wing and how it looked. Now here, in the maxillary teeth, I just cannot see any bone, interradicular bone, intraradicular bone. I cannot see the cementum, I cannot see the lamina dura, I cannot see any periodontium of the maxillary teeth. And why is that? Because the patient did not bite properly on the phlegm. The mandibular teeth are in good position like the phlegm wise, but if these teeth, the maxillary teeth would have been just, you know, 1 millimeter away from the mandibular teeth, if the patient would have bitten on that occlusal phlegm properly, you would have had a proper thing. So that is the basic most glaring error, okay. There is cone cut on the distal aspect, yes, but that is not the main technical problem. If there was a cone cut, but if the patient would have bitten properly on the occlusal phlegm, still you would have been able to see a bit of periodontium of the maxillary teeth, but you just cannot see it. And the question is specifically asking why you can't see that, and that is because the patient did not occlude on the phlegm holder, option E. You understand? The rest of the things are fine in the bite-wing radiograph. So this is how you solve a question. So this question had a mixture of a bit of radiology, it had a mixture of preventive dentistry, conservative dentistry, your clinical expertise, all of those things. So overall a very good question, and expect such kind of questions, and this is how exactly your questions would be in exam. You see, just for one question how much of brain you have to use. Now imagine you are solving 14 such questions in 2 hours. Then you have a 1 hour break, again 14 such scenarios, basically 70 questions in 2 hours, 1 hour break, again 70 questions in 2 hours, and the next day also you have to repeat the same process. Your mind is gonna be so tired after the exam, you just would feel like, you know what, I don't want to think anything, just take me out types. So it is an exhausting exam. So take it as a challenge, love your subject. If you really love it, you will enjoy solving it. If you are scared, stressed, put pressure on yourself, I have to answer each question correctly, that will be making your life difficult. So don't do that. Take it as a journey, take it as a challenge, enjoy the exam, and be very confident of your concepts. And to, again, like I mentioned, strengthen your concepts. This is an amazing book. Try to have it. You will just love it. Like, I have got rave reviews about this, like it took me hours and hours to make it, but this is practically serving you the concepts from the ADC resource on your platter, saving tons of your time and making you go through the subjects. I have practically taken all the ADC related questions from ADC resource, compiled into a book and dishing it out to you. So have a nice day. Bye bye.